The third session will be about supportive care in myeloma, and in my mind there is nobody better than Dr. Al-Ola Abdallah, who's going to talk today about supportive care, how do you manage infections. So Dr. Al-Ola is a myeloma specialist from Kansas University, and he recently has offered his collaboration with the Saudi Myeloma Group. So thank you, Al-Ola, and the floor is yours.
Thank you very much again. Okay, so thank you everybody, and I promise I'm going to try to make it very quick as well. So we're going to talk about the supportive care in myeloma, and I don't have any financial to disclose, but why do we need it? I think that's a very important question, and it comes from the fact we're really doing great in myeloma treatment, and not only that, we have a good survival for patients. We're talking about survival from one of, maybe 20 or 30 years ago, about 2 years survival for myeloma. Now, with standard risk, we're seeing 15 years of survival. And that means like patients are living longer with myeloma, and unfortunately their disease is not curable, so they need treatment. And that means that we have to actually kind of balance between the quality of life and the treatment itself, in order for them to continue their life. And this is one of the major things, and it's important actually section, is to understand the supportive care. And always to remember that every time we have a newer treatment, we really have newer obligation is to actually create more supportive care for these patients in order to tolerate the treatment and continue their life. So the goals of the supportive care is more likely is to always evaluate the quality of life, and also the goals of care. For a myeloma patient who's like 40, 45-year-old, you have to remember it's different from a person who's on dialysis, 82-year-old, have a history of stroke, So we want to make sure also we meet the goals of care for all the myeloma patients. We're not just going to be very aggressive for everybody. So a patient who comes on a wheelchair, and he's 40-year-old and he was a very active person, because of the back pain or fractures, we want to make sure that their fracture is, and their myeloma is resolved in order for them to get back to their quality of life. That's the whole purpose of the supportive care. And to focus on that, we focus on many things. We focus now on the bone health, which is a very critical thing. It's very important, and we'll talk about that deeply. There's the anemia and fatigue. I think we don't use very often, because most of these patients, thankfully, after the treatment, their bone marrow recover and they don't need any, growth factors or any transfusions. Renal protection is a little bit tricky. That we always ask ourselves if the patient have, ended up with end-stage renal disease due to the myeloma, how quickly we can take them off the dialysis, so we have to act very quickly for these patients. And of course, we have the thromboprophylaxis. We don't want patients to develop any venous thromboembolisms while they're taking immune modulator drugs. And neuropathy is a very critical treatment, with using Velcade. We don't want these patients to have, unfortunately, bad neuropathy that calls them, after we take them off the wheelchair, to put them back on the wheelchair because of the neuropathy. That's really bad action. But the most important subject that we're talking about is the infection rate that we actually consider is raising up, and there's a reason for that because the cellular therapy has increased the risk of infection, and this is becoming a very critical event that we have to kind of like provide better supportive care for these patients. So bone health, I think I want to talk a little bit about this picture. It's just Sarah Newberry, the first documented myeloma patient. And this is one thing I always try to teach my patients and the medical students. This is the reason why we treat myeloma. We don't want these patients to have fractures. That's the reason for that. And this is a very important thing, is to understand why our treatment is much better now. Bone health really is considered as a very important thing. So you can see that patients, when they have, fractures or lytic lesions in their back, they can't stand up. Even pain medications can't help them. They come to your office with a wheelchair. And whatever you start them with, you have to actually start treating as soon as possible in order to kind of relieve the pain. And you can be surprised exactly how many patients, after a couple months of treatment, they're coming back, either they're on a cane or they're walking back to their normal. So you can see exactly a big transformation after you treat these patients. So we're lucky that we have a lot of options of therapy. So to understand the bone health, we have two major drugs that we use in our center, zoledronic acid and denosumab. And what lytic lesions happen in myeloma is that the myeloma cells, through some of the cytokines, the MIP and the interleukins and RANKL, it actually activates the osteoclast, and some of the cytokines like DKK1 inhibits the osteoclast and causes imbalance and causes more lytic lesions. So the zoledronic acid, as well as the denosumab, really plays a role to actually inhibit the osteoclast, so it stops the lesions to continue for these patients. And that's the mechanism of action why it works very good. Of course, beside, you have the anti-myeloma drugs to stop the cytokines in order to kind of like stop these lesions to continue. Now, The biggest question have been asked here is that we use zoledric acid denosumab, but how often we use that, and I'll tell you what our practice is, more than this one. Pimidronate is not very commonly we use, but the zoledric acid, we use it monthly. I use it, if the patient's going to go for a transplant, I use it monthly. And then after the transplant, most of the patients are going to go very good partial response, so I move it to every 3 months, and I limit it for 2 years. I don't do more than 2 years. And, if the patient relapse myeloma, I restart back zoledric acid. So this is how I practice in my field, I stopped doing more than 2 years because I didn't see any kind of good studies or data to show any better results. While, talking about other options, if the patient doesn't go for a transplant, it's a little bit tricky. I do every month, but if the patient achieves VGPRR, I will go ahead every 3 months. And there is a reason it's more convenient for the patients with multiple myeloma. The denosumab or Xgeva is like a sub-Q, and I know some colleagues will prefer using it because it's sub-Q injection. It's monthly treatment. It's non-inferior to the zoledric acid. You can use it monthly as well, but here's what I do in my practice. If the patient is on it, I'll do it the same as zoledric acid. I don't change it. I give it monthly prior to the transplant, and then I change it every 3 months for 2 years. I don't do it more than that as well. And if they're also non-eligible for transplant, I do it monthly until they get to VGPR, and then I move to every 3 months prior to that. The only time I prefer denosumab over zoledric acid is in patients who have renal failure or on dialysis. That's the only time. Or if the patients say, I don't want to give an IV Zometa, because most of the drugs are injection and oral pills induction therapy. So if that's their preference, I will respect that. Another reason is that if the patient have a very bad reaction, which a few cases of patients who have zoledric acid and they can't tolerate that, I'll just move on to denosumab. So these are the only reasons. So common thing is that everybody have been actually thinking that the osteonecrosis is commonly seen in patients with denosumab more than, actually zoledric acid more than the denosumab, but it actually have the same frequency. And the common thing is to understand the reason why patients have the osteonecrosis is that jaw is a very active, a bone because of like the chewing. So patients have to have the osteoclast activated all the time. So when you actually add the denosumab and the zoledric acid, you're inhibiting the osteoclast, and it causes more sclerosis because you're stopping the remodeling. So that's the reason why these patients are always high risk for osteonecrosis, and that's the reason why you have to make sure these patients are seeing a dentist every 6 months. So this is a very good study. This is what led to approval of denosumab instead of, in patients in case they don't, as an alternative to zoledric acid. It didn't show it's non-inferior, so it had the same efficacy. But again, the only time I used denosumab over zoledric acid, it was only in patients with renal failure. And this is a summary that I talked about that, and that kind of compared. Pimidronate, I don't use it anymore in my practice. The other thing I want to mention here is that sometimes in denosumab, one of the other reasons I tried to avoid using it is the persistent hypocalcemia in some of the patients. A couple of patients I have to admit to the hospital because their calcium level was very low. I have to replace it while they're in the hospital. So staying in the bone health as well, is the non-pharmacological intervention. We have great treatments, but getting patient in remission, giving them Zometa and pain medications, maybe it's not enough if the patient already have a fracture. And I really actually tell you that the balloon kyphoplasty have played a really important role. In my practice, I have 80% of my patients actually, they stop or wean themselves off pain medicine after getting that procedure. Now, to be honest with you, I don't know exactly the role of radiation therapy with our great treatments in lytic lesions. I know they say it's actually to prevent or it's to relieve pain, but by the time I do the treatment, I give the patients the kyphoplasty, their pain has gone away, after evaluation for the radiation therapy. So the only time I will use radiation therapy if the patient pain persists after I start the patient on treatment and they're in remission, and I do the kyphoplasty and they're still in pain. So this is the only time I will just consider like doing a radiation therapy. Surgery is just only kind of like a reserve for fractures, for instability more likely. So that will be my case in the radiation therapy. Now, moving forward, I think the infection is now a very hot topic, and there's a reason for that, because cellular therapy, especially bispecific, we're using it very often. And there's a reason why we're seeing that. BCMA is present not only in myeloma cells and plasma cells, so we're depleting it and depleting the B cells, and that's called low immunoglobulin. Don't forget, it's a redirect therapy, so it causes an imbalance of the cellular immunity, and that causes the more infection for patients. And to be honest with you, in the past, I never used to see like patients getting PCP and fungal infections. I'm starting to see that while we're using these bispecific treatments, which is kind of shocking for us. But as much as effective, it causes a lot of infection. And don't forget, unfortunately, most of these myeloma patients have been on long-term treatment, so they're always continuous treatment, so their immune system is always down. So infection is considered as a worst thing. So this is a very important study to show you how much infection is impacted by teclistamab. You can see here is the first slide that the B cells actually is depleted, and that's, that eliminates the normal cells, which is very important for the immune system. The vaccination is always tricky because you give a vaccine and you give teclistamab, you can see that the response of the immune system is going to go low, and I'm not surprised about it. And the question is that how often you have to vaccinate these patients, and if you want to check the serology for these vaccines. But more important is to prevent these infections to happen. And I think the only thing that we have, or one of the things that we have here is the IVIG, which great news is that it helped a lot to decrease the risk of infection. So that's really highly recommended in bispecific patients. Now, the IMWG did a really great job for putting like a good guidelines, and I think it's a little bit tricky. We all give patients acyclovir Valtrex for these patients for preventing any shingles. And I always tell patients, if you get a Shingrix vaccine, you still have to get the Valtrex and acyclovir. Do not stop it because you don't know exactly if the response is going to continue after that. PCB pneumonia, Bactrim, or any other drugs like Dapsone, if they can't tolerate the Bactrim or Mebron or pentamidine can be used. Antibacterial and antifungal, if the patient is neutropenic, I highly recommend to start these patients on treatment. Other viral like HBV, like entecavir, is used also as well for preventing of any reactivation. And IVIG is kind of like, highly recommended for all patients. So we kind of recommend it, especially if the IgG level is less than 400. Now, this is when I was telling you guys why, when I asked the question, which one of the three bispecific you will use, and we recommend teclistamab or lenalidomide or linvoseltamab, this is what I tell you. I look at which one I can get a lower frequency. It's because I believe that the lower frequency, I can have lower chance for infection, lower chance of treatment-related morbidity. So if I have that, that's be good. And you can see here down that once you're switching from weekly to every 2 weeks, you have a drop of the infection rate from 33 to 15%. So it's really important why we actually try to decrease the frequency in addition to provide other supportive care treatment. Now although this is a retrospective study, I want you to be aware about, it really actually helped us a lot to kind of like provide better care for patients. And now we were telling about that IVIG is given. There is prospective studies, by the way, about when to actually start IVIG. Primary prevention or secondary prevention. So some doctors still use it like if the patient develop a first infection and an IgG is less than 400. In our institution, we really don't care about if you have the infection. We just give it to the patients if their IgG level is less than 400. Now, talquetamab is the main private sector, I will say that, and the reason of that, it's really a great treatment, as Dr. Angel was talking about how we use it in bridging therapy. And I think the biggest thing is that, can we move it a little bit up front? And I want this question to be, we know there's tri-specific coming out. We know the talquetamab is going to be combined with other therapies, but we have to understand the quality of life is going to be impacted. That's why it's still in the lower case. The efficacy is there, but the side effects is unfortunate. And I think this is the only thing I think is really harming us, because the majority of my patients in talquetamab, they're taking themselves off talquetamab because of the oral toxicity. That's the only option they have, and they prefer to take themselves off of it. So, what can we do to prevent that or to decrease that? We tried everything: increase hydration, saliva substitutes, nutritional, all the tricks, even dexamethasone rinds. I have not seen any effectiveness, but there's a clinical trial that they want to compare talquetamab versus dexamethasone rinds, oral Lyrica versus oral clonazepam. We really need something to help us out, and I think this is the only problem that we face. But we face it that if the patient is responding to the treatment and I want to try to decrease the side effects, I kind of prefer to decrease the drug dose and decrease the frequency in order to keep the patient on this treatment. Dermatological side effects, as much as it's like, sometimes it could be like, annoying, like the peeling of the skin, but I think it's really treatable and it's also reversible. I have not had any problems with that. I have only saw one case of grade 3, rash in the patient. We treat them with oral steroids and we decreased the dose and the patient is doing really good and responding to the treatment. So I think that this is actually kind of like important to understand that skin toxicity is not really a big concern, especially if you kind of do a dose interruption and dose reduction for these myeloma patients. Now, the vaccination principles, which is kind of the last thing, is kind of also part of what we do for myeloma treatments. And we always focus on how we can actually provide the best care for these patients in terms of supportive care. And we have to understand that, it's a little bit tricky. It was easier when we understand after stem cell transplant that patients get vaccination after they're done with the transplant. You've vaccinated them in 6 months, and you don't give them any live vaccines up to 2 years, which includes influenza intranasal, MMR vaccine, oral polio or BCG, or yellow fever. The problem now we're facing is that a couple of things, daratumumab, we don't have a clear answer when we can give the MMR vaccine for these patients. And also we have a problem with teclistamab and the bispecific because they're still in these treatments and we're depleting their B cells. So we are still struggling to understand the role of these live vaccines, and especially I don't know if you guys heard about some of the outbreaks that happened in the measles. I have patients coming to me and they asked me if we can give them MMR, and it was very difficult. If they were CAR T cell, the rules of our institution, it's to follow the stem cell transplant, do not give them any live vaccines until 2 years after the CAR T cell. So, patients, when they needed, like we evaluated their measles response, the measles serology was very performed, so it was very difficult to give them the live vaccines at that time. So I think that's one of the major things that we really need to address about the rules of the vaccines in cellular therapy, and we have to have a better guidelines and what we should do in these patients more than for the transplant and all these. What about vaccination for the close contacts? Of course, for healthcare providers, of course, that we always kind of get an influenza vaccine, but we always recommend for patients or caregivers who actually, stay with their, with their loved ones, is to kind of like also receive the influenza vaccine. The high risk for travel in high endemicity areas, any kind of occupational exposure, chronic liver disease, we recommended hepatitis A, and in addition to that, with a history of end-stage renal disease and hemodialysis, we recommend hepatitis B. Polio and TDB is also recommended. If the patient's relatives are young, younger contacts, military recruits, meningococcus is recommended for these patients. Now, the serological response, especially after patients receiving cellular therapy, is really tricky. I will say that most of my patients, when we do that, we know that they're going to be really down, but I don't think it's something that we do it a lot for our myeloma patients. Some of them are simple and inexpensive, like, hepatitis B and tetanus. Some of them are very, very, high-tech, and, it's very tricky. Streptococcus pneumonia, we have to check over 14 serotypes for pneumococcal polysaccharides in order to evaluate if they have a good response or not. So I think the vaccination era needs a lot of clarification in the era of cellular therapy, especially we're talking about CAR T, BCMA, and bispecific BCMA, and the GPRC5D. We need more kind of like clarifications and education in that case. Now, my summary here for all of us is that, I still consider zoledronate acid, and my colleagues disagree with that, but for me, I think IV zoledronate acid is still a standard of care, I use the denosumab instead of the zoledronate acid in renal impairment if the patient cannot tolerate that, so I have that cases. I still go with the monthly treatment prior to the transplant, or if the patient achieves a very good partial response, and then I move to every 3 months, and 2 years is still my limitation. I don't exceed more than 2 years. If the patient relapses, I restart the back. It makes a lot of sense, especially if the patient have a history of lytic lesions. I think, kyphoplasty is really a very important procedure that I have seen really impact on quality of life. For infection, I'm really careful about that. I have seen treatment-related mortality due to infection. I think we're heading toward bispecific to be a combination therapy. I believe that we have to be very aggressive in infection in order to see the efficacy and also the quality of life improvement. So getting IVIG and keeping the patient's cytopenia, neutropenia, with the growth factor shot, I think that's very important and critical. Talquetamab, I think we need a little bit more work on that, especially with the oral toxicity. I think That will require magic, I think, not only magic mouthwash, but really magic, to have a better response. And one of the options, I think, we have that discussion that if we are combining the treatment, that I think all the trials have to be a definitive treatment, which means, instead of giving it indefinitely, to give it only for 6 months or a year at least, because I think that'd be the only option that will keep patients with a better efficacy and less side effects. I think that's it, and thank you very much.